Let's get digital, digital. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. Let's get digital, digital. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. Let's get digital, digital. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. Get digital, digital. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. Let's get digital, digital. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk. Let's get digital, digital. I wanna get digital. Let's get into digital. Let me hear your iPad talk. Your iPad talk. Let me hear your iPad talk.
Welcome. EUCOMS goes digital this evening. Welcome. Glad that you joined our webinar. My name is René Kiet. I'm the chair of the European Community Mental Health Services Network, EUCOMS. It's an international learning network of community mental health services, and we host these webinars at least 4 times per year. And this time the topic is on digital care, on the possibilities of digital care within the context of community mental health. And as always, we open our webinars with a person with lived experience. So I'm really happy now to give the floor to my colleague, Dick van der Vlucht. Dick, please.
Thank you very much. I was asked by René to open this meeting. I'm taking over the role of Marieke Noord. And what is expected, as I've learned, that a person with lived experience opens and closes the session. Well, I qualify on the issue of lived experience. I dream big, and online mental health fits in perfect. In my opening, I also have to tell you about Online Recovery College, and that's easy. In short, we don't have an online recovery college at North Holland North yet, but I'll explain that for you. So I'm here to take over from Marieke, and I think the organization might regret this from the beginning. I graduated computer science with artificial intelligence as a specialization about 37 years ago. And finally, it's booming. I have my own coach company, and I'm a peer worker since 2015, and I'm advisor of the board. I worked in a FACT team from 2015, and since 2017, we have 3 recovery colleges spread out through North Holland. Well, as a disclaimer, I'm not the marketing manager of GGZ North Holland North. And when I read the invitation, we are thrilled to invite and discover how North Holland North is leading the way to groundbreaking advancement in digital care. I thought, that guy must have the same diagnosis as I do. Like Phil Collins, I think you should hear both sides of the story. Some years ago, I wanted to go the digital path for my personal benefit, because I like to travel Europe as one of my dreams, combine work and holidays. And I also claimed some domain names for the digital peer worker. I talked to Andreas and others, and they liked the idea. But it didn't go that well. One person, Dick, it will grow too big. We like your enthusiasm, but no. Although I know the successes within our organization, like Andreas, the digital sofa, the sofa, and I believe in it. I participated in many, maybe too many sessions on the Recovery College. And after a while, 3 people were offered 4 hours to work on it. But I rejected that. And sometime later, one person got 10 hours to work on the Recovery College, did online Recovery College. I rejected again, stubborn as I am. Because when I want to do something, I want to do it good. I've learned from my vulnerability. We have debates with our communication departments. We were trying to launch the V factory. V from veerkracht, which means resilience, verbinding, which means connection, verdieping, depth or level of intensity, and verandering is change. And we designed a nice homepage, factory-like. I'm a positive guy, although you might think different now, but this is my reality. It's very, very, very difficult to get it started and rolling in the organization. Especially peer expert salaries and investments are not supported by insurance companies. It all has to come from the organization's overhead. But I like to close this opening positive. 2 months ago, we started or restarted a 100% online team, intakes, etc., etc. Peer workers have a prominent place in that, and that's nice. People from all over the world join in this. Okay, that's enough. And for the good news, I'd like to transfer to Andreas.
Thank you very much, Dick. So I hope I'm going to bring the good news. And thank you very much also for standing in for someone else at such a short notice and for starting with your presentation. I was also told to start with an important announcement, and that is there's going to be a Q&A after our presentation, and I'm asking you to please use the Q&A button at the bottom and don't put your questions in the chat. And if you could start the presentation, please, with you. Yeah, thank you. I actually had the pleasure to give the EUCOMS webinar just about 2 years ago. And I talked about my experience as a digital psychiatrist working out of South Africa and seeing my patients back in Holland. And I left actually with a take-home message, and that take-home message was digital mental health is inspiring, it's exciting, and it's here to stay. And what I want to do today with you is actually look at what we achieved over the past 2 years, but also look forwards together and look at future developments in digital mental health. So I invited a couple of my colleagues, experts in their field, to talk about their particular experiences and ideas and also expectations. And I would like to actually start with introducing ourselves and want to start with Nancy.
Yes, hi all. My name is Nancy Major, and I'm working at GGZ NHN. I started there about 17 years ago as a psychiatric nurse. And from there, a few years later, we've started a project, and that was the digital prevention team for patients to reach out by telecare, by video conference. And after that, I started working as a manager at the Youth and Family Division of GGZ Noord.
Thank you, Nancy. René?
Thank you. Hello, everyone. I'm René Wubs. I worked also 70, 80 years by GGZ Noord, and I was a manager for the forensic mental health. And the last 3 years, I'm the manager of the digital transformation by GGZ Noord. And later I will tell more about it.
Thank you, René. My name is Andreas Lamerts. I'm a psychiatrist and child and adolescent psychiatrist, working for the online unit and also working for a regular outpatient clinic. And I'm a director of the digital focus program of our organization. If you guys wonder, well, what the heck is he doing with his hand? I'm actually waving at Ovidio to change the slides. So because we had some technical hiccups, and this is why you see me sort of raising my hand. I'd like to look back at the achievements of the past 2 years. We actually started a 100% digital child and adolescent outpatient unit right after my return from South Africa. And we started quite small, and that unit has been growing over the past 2 years, and Nancy is going to talk about that in more detail. And Dick just mentioned that as well, that we started just recently a 100% digital adults unit. We are quite proud of, and we actually hope to combine the two units in the near future, hopefully next year, to improve the cooperation between the two entities. We also have a digital prevention team in place. That's a team available 24/7. And it's actually in place to prevent crisis situations. We also started right in the Corona pandemic period to have all of our psychiatrists who are on call to do the psychiatric crisis assessment digitally. It means that there is an actual team of, it's a hybrid form. There's actually a team of 2 colleagues. It's a psychiatric resident and a psychiatric nurse, and they will actually see the patient physically at a location. And the actual psychiatrist on call is going to call in via video conferencing to actually do the psychiatric assessment. We also have a user portal in place, and it's used for every patient above the age of 16 to actually enter their individual patient record. And there's also been a decision made for a new, more innovative electronic patient record. Last but not least, and I talked about it 2 years ago when we had the plans to actually open an innovation lab, we transformed space on the top floor of one of our buildings into a meeting place, a meeting area, a place to think, to discuss, to develop, and also dream about the future and digital development. And I now want to hand it over to René.
I'm sorry, I guess we changed. So
Hand it over to Nancy.
yes, thank you. Okay, yes. So I would like to take you into the online mental health care for youth, for children and adolescents, as Andreas already mentioned. And what we do is care as usual, only digital. So I'd like to start with some history, and I try to raise my hand also. Yay, it works. Because I'd like to share with you how we started this this online team, and We started with experience. It has been gained within the organization with adults care online, but the adult care was not in a team. There were some psychologists, I guess. They were working from. They were working online, and they can be added to a treatment just for specifically that part of the treatment. And then in 2019, Erik Koch, who then was a manager in GGZ Noord and now is one of our directors, his dissertation was specifically about this subject, youth and family online. And after that, as Andreas already told, Andreas went for a pilot to South Africa. So we could experience what it was like for, of course, the patients and also for colleagues if the psychiatrist is only available online. And then in the meantime, there was the corona pandemic, and it brings, of course, not only good things, but some good things came out of it because it helps us a bit with the online working. So all of the above made that in January 2021, there was the start of the online team. And the online team is, especially in this case, it is for children and their family, of course, from the age of 8, maybe. Yeah, I'm sorry, I was waving. I knew this was going to happen. Okay, but it's okay. I'd like to show you a video. And in the video you can see how it works online.
Het zijn soms net eye-openers dat je denkt, oh ja, zo had ik het ook kunnen oplossen. Het is niet dat je dan fout bent, maar wel dat je de situatie daardoor net anders kan benaderen. Onze zoon die zit in het autisme-spectrum, wilde de overstap van speciaal onderwijs naar regulier onderwijs. Daarvoor hebben we de hulp ingeroepen. Wij zijn eerst naar de huisarts gegaan, die heeft hem doorverwezen en zo zijn we bij de GGZ Noord terechtgekomen.
En dan wordt er contact met je opgenomen en dan krijg je ook de keuze om te zeggen van wil je gebruik maken van de online poli of een intake krijgen op locatie.
Wij kregen toen de keuze inderdaad tussen face-to-face contact wat langere wachttijd had of via de computer dan. En hier konden we eerder voor terecht en dat hebben we gelijk aangegrepen. Onze oudste die heeft zelf begeleiding 1-op-1, ook online. Daarnaast doen wij 1-op-1 begeleiding als ouders zijnde.
Na aanmelding bij onze poli doen wij ook de intake. Die bestaat uit een eerste gesprek met ouders en het kind. Die wordt dan eigenlijk gevolgd door een individueel gesprek met het kind zelf. Een psychologisch onderzoek of een psychiatrisch onderzoek. Daarna wordt er nog een gesprek gedaan met de ouders om de ontwikkelingsanamnese af te gaan nemen. Om te horen van, nou, wat is er gebeurd eigenlijk allemaal in de voorgeschiedenis. Mijn collega Sarah spreekt eigenlijk de zoon van Valerie. Dat is de individuele begeleiding en dan leert hij de dingen die hij nodig heeft qua behandeling. En daarnaast spreek ik op regelmatige basis Valerie en haar man om te kijken van hoe kan je je ouderschap daarin beter vervullen.
Onze zoon die is zelf zijn afspraak aan het inplannen aan de hand van zijn eigen lesrooster. Hij doet dat ook zelf regelen. Vaak weet ik niet eens wanneer hij een afspraak heeft. Krijg ik ineens een sms van oh, hij heeft morgen weer een afspraak. En dan regelt hij het ook zelf weer. Dus daar hebben wij geen omkijken naar. Je kan het doen wanneer je zelf de tijd voor hebt. Je hebt geen reisafstand, geen reistijd. Kan je niet alle twee op dezelfde plek zijn, kan je toch alle twee erbij aanwezig zijn. Je bent in je eigen veilige omgeving, waardoor het soms ook wel juist prettig werkt om dingen wel te kunnen zeggen.
Het contact met ouders en met cliënten doen wij vaak gewoon via de mail. Of we sturen een berichtje en zij kunnen ons eigenlijk ook via die manier bereiken.
Is er een situatie geweest dat we denken van hoe hiermee om te gaan? Kunnen we het ook gelijk mailen? Is het noodzakelijk? Reageert er gelijk terug?
In geval van crisis maken wij net als de andere locaties gebruik van de IHT-teams van GGZ Noord. Dus wij hebben die mogelijkheid om die in te schakelen, zodat er dan mensen bij de cliënten thuiskomen. Met mijn collega's onderhoud ik eigenlijk ook veel contact gewoon via beeldbellen. En als we dat willen, als we vastlopen met z'n tweeën en we zeggen we hebben expertise nodig, kunnen we dat ook altijd inbrengen in ons team om een psychiater mee te laten denken of andere collega's. Het voordeel bij het online team is, en dat wij mensen in het buitenland hebben werken, betekent het ook dat wij niet altijd alleen maar tot 5 uur werken. Dus in de avonduren geven enkele collega's ook gewoon behandelingen. Ik merk dat sommige mensen vinden het eigenlijk ook wel heel prettig om gewoon online behandeld te worden.
Hij zit nu op het regulier onderwijs en het gaat heel goed met hem. Eigenlijk herkent de mentor nu niet de dingen die in het verleden gebeurd zijn, omdat het gewoon eigenlijk heel goed met hem nu gaat.
Yeah, so this video shows a nice example of how it works online. And in the video you saw Peter, and Peter is one of our psychologists. And as you can see here at the left, the different disciplines who are working at the online department. As you can see, similar to the location teams, we have a multidisciplinary team. And on the right, you can see we have colleagues all over the world now. And that gives us more opportunities to attract or to retain colleagues. If, for example, a colleague wants to work abroad, maybe they want to go live somewhere else for a few years, then they can remain connected to our organization. And working from different countries does present different challenges, of course. So, for example, we have to look at what time we have to meet. And then we meet at 2 o'clock in the afternoon. And then we say, one person is saying good morning and the other one is saying good night. So that's funny for us to experience. But above all, it makes us more flexible for our patients. Next. So here you can see the online treatments we do, like intake, diagnostic, assessments, and of course the treatment. And we notice that sometimes patients are a bit scared to start online, but quickly they see the benefits because they are in their own safe environment. And they show us their rooms or their house or their pets, of course. And if things become difficult during therapy, they can, for example, grab their favorite cuddly toy. So that helps in the therapy. So I was looking back in the numbers just for today to make sure I know what the numbers are. And it was funny because I saw in January 21, there was one patient in care of the online department. So, and now today there are 140 patients in care right now at this moment. So we are growing, and we're still growing because we never have vacancies, because I get mails weekly if we are taking any more disciplines into our team. So that's good. So we can grow. If more patients are coming, then we can grow with our disciplines. So next slide. But still, there's more research needed. And now there's a current research going on. And we want to know if under normal circumstances, video conference calling therapy is comparable with treatment as usual. So Alice ten Braken, she's started this PhD together with the promoter, as you can see. And the hypotheses are, with online therapy, symptomatic and social recovery is comparable to treatment as usual. And the online therapeutic relationship is assessed, the same as for treatment as usual. But we don't have the results yet, so we have to come back, I guess, in another 2 years to show them with you, to share them. And of course, we're very curious. Okay, I started my presentation with this slide. Care as usual, only digital. But I don't think that's enough. Because we're increasingly looking for not just the same, but for things we can only or even do better online. So I hope we can give you another update in 2 years because more things are coming. So that's it for now. And I think I'll give the word to René.
Thank you, Nancy. Yes, I will tell you more about the digital transformation because GGZ Noord-Holland-Noord faces a major challenges. And I think you can recognize it because we have a lot of aging population. In the coming 5 years, a lot of our employees retired. We also have a staff shortage by the younger people because they are electing if it is fun and it's not fun, they go to another job. I have a son, he works 3 years and he's already in his third job. So I learned him it's ook good to stay by a company. But my daughter, she is a teacher and she is 8 years at the same school. That's sometimes there's hope. But we have staff shortage except for the online teams. And Nancy told us. So we offer from practitioners, they say, next year I'm gonna live in Curaçao, but I like to work for your company. So it's easy to get new people for the online teams. But at the teams at location, we have a staff shortage. And we have also waiting lists for the clients and rising healthcare costs. So we had to need a strategic plan and we have to use digital solutions. There's also rapid digital development. How can we use and provide if investments in digitization and hopefully it can overcome those challenges. But I always said it's not a goal, it's just a tool to get us further, to work more effective. Yes. And we have in our company, GGZ Noord-Holland-Noord, a strategic policy, and they said we have 4 pillars, and one is connect in networks, another is human research and development, the third is digital focus, and the fourth, sustainability. And now I will tell you more about digital focus. I'm the manager from this program, and we have 3 key points, and I will elaborate it. It's data-driven work, digitizing the offering within the customer journey, and reducing administrative burdens. Next. Yes, data-driven. It's not new if I told you we are in the data decennium. Data is the new gold, but can we unearth it? And another colleague said, it's not good to talk about data-driven. We better can talk about client-driven by using data. And I think he's right. It's better to talk about using data. For example, when we have questionnaires, the outcome in questionnaires, we can use it in treatment. But what's the influence of artificial intelligence? It's very upcoming now. Dick told us many years ago he had a study, but now it's booming. And we have the possibility, but also the risk of the long language models at ChatGPT. It can help us if we write a letter, but we didn't use personal data in it, so in kind of large language models. And we also have a new team. It's a data IE team. It's in we had to develop it, and I will tell you more about it. Next. Yeah, and we also digitizing the offering within the customer journey. We have a lot of online teams. Nancy had told about the youth online team, and Dick told you about the 100% agile online team. I will tell you more about the Digital Recovery College, and we also have Digi coaches in each team. It are digital natives, and they help the colleagues to get more digital capabilities. And for example, the last 3 days we have a big truck on by one of our locations, and it is a truck against the cybersecurity. We want for our executives and the DigiCoaches to learn about ransomware and other things and the danger and what you can do against it. Our board, the directors, all they go into that truck, and they've learned a lot about it. And so we use the DigiCoaches to learn more from the digital capabilities. Another important point is to the control by the client. The client has to choose if they want to follow the treatment online or if they want to go to the locations. Another example is a psychiatrist in training. He has developed an app, and it is the Informed Client. He worked on a ward, and he gave to one of his clients a flyer. And next day he said, "Did you read the flyer?" No, he didn't read it. And I thought maybe I can make a vlog, and I sent it to him. And so he made a lot of vlogs, and so he informed the client about medicines, about the different mental health units, and the clients can learn about it. It's a nice tool. Next. And yes, we all know the administrative burdens. I heard the practitioners, the nurses, they spend a lot of time to register in the electronic client record. And we thought, can we reduce it? Now, with our data and IT team, we developed 3 use cases. And to our board, we said at the end of this year, we have a roadmap by the 3 use cases. But the first is ambient report voice control. The artificial intelligence, we use it by our intakes, and the conversation is converted into text and sorted into a correct category by AI. The voice transcript it to a category medicines, a category mental health of a category, and in our electronic client record. We had to train the artificial intelligence. And last week, I was by a webinar from another mental health organization in the Netherlands, and they already had developed our use case. So we are in discussion, have we buy that software and we can use it, or won't we develop it by ourselves? I think we're going to use the software. Then another use case is ADHD diagnostic, screening with artificial intelligence. So artificial intelligence looks at the history and looks at the letter from the art, and then with word mining, maybe it's possible to make, oh, this is about ADHD and the other isn't. So that we not have a long waiting list at the ADHD diagnostics. And we work together with the University of Amsterdam, and we work together with the University of Utrecht. One of our PhDs want to pick up this use case. Our third thought was about an expert bot, learning with artificial intelligence. It's a kind of interface for different disciplines. And you can see it as a kind of knowledge base for GGZ Noord-Holland-Noord. And we have scientific knowledge, experiential knowledge, and practical knowledge. And so we develop our own knowledge graph, knowledge base. Yes, and yes, it's a little bit the same, but I shall go straight to this sheet. The Recovery College. With my colleague Marike, she's a peer worker, we try to go from the Recovery College to a digital Recovery College, and it has a lot more possibilities. And as Dick told us, she has called it the Fee Factory, and it is free educational workshops, courses, and you can read it on this slide, the next. And the goal is to create an opportunity for people seeking more resilience to work and participation online at any time, any day, at any place. Everyone is welcome. This is not only clients from GGZ Noord-Holland-Noord, also citizens who want to learn about recovery, resilience, they can find us. We don't want to exclude anyone. We want to offer a diversity of tools, groups, solution people to start working direct online. Next. This, resilience is very important. It's about empowering people, peer support in groups and courses, online challenge. The values is self-efficacy, equality, and non-judgmental. And we also use e-learning model. And next. You also can deepening, and then it's, for example, the peer expert gives a rep training. It's wellness recovery action plan. You can talk about the meaning of life, recovery, stigma, and we also want to create a hub function to linking to other websites. And Dick told us, but it's a discussion with our marketing and communication department, but they said they had to stay on our website, but we thought about it's good if another company has created something good, we want to link to them. And nowadays we have ook a celebration with our spiritual caregivers. They have webinars, they make vlogs. And it's, yeah, the connection is very important. We ask the client if we want to create a digital recovery college, what is important? And they talked about loneliness, and they're feeling lonely, and they want to meet other clients and peer groups. And by the recovery college on location, they give a group, and the clients, they said, hey, we want to start a running group, and they make it by themselves. Now, it's very important to connect. And online, it's a pity, but we can help on another way. We're helping each other by reducing feelings of guilt and shame, and maybe execute self-management groups. The next. And the thought from Marike and mine was to work on the change. And digital recovery college is not the same as a recovery college on location. Instead, it's a caterpillar, and we want to make it a butterfly. We have a lot of challenges, and it isn't so far, but we are open for new ideas to create maybe a new app of use a chatbot, and also the influence of artificial intelligence is very important. So over 2 years, as Nancy told, maybe then we have a good digital recovery college, and we can tell you more about the experience. And then the future, what will bring the future? It's not about only the recovery college, it's about the digital transformation. If you think about artificial intelligence, will it help us, or is it the real life? Is it just a fantasy? Now we want to see how we develop, how we discover, and it's maybe one of the points for our discussion. I'll hand it over to Andreas.
Thank you very much, René. Thank you very much, Nancy. I've been checking the Q&A button, and I don't see any questions yet. So I'm asking you, please feel free to put your questions in the chat. And what I find really fascinating, I just went through the actual chat, and I do see people from all over the place. It seems like we have people joining us from places in Africa and several places in Europe. So it's I'd be really curious to also hear from you about your experiences working digitally. Maybe you would want to share it with us.
Yes, exactly. That would be really nice. And also the people who you can put your questions. I see one question now in the Q&A.
Yep, there is Koen is actually asking a question about group therapy, and he's wondering whether group sessions are actually being organized, or if it's only going to be one-on-one individual contact. That's a good one, because we actually started with group sessions as well. When we started the online unit for children and adolescents, we actually started with a one-on-one individual contact, but very quickly we decided we have to sort of broaden it and also start with group sessions. And we actually have that in place for several groups. Maybe Nancy, you would want to elaborate on the different groups we have.
Yes, let me see which groups we now have online. I think recently the gender diversity group started. And we have this, I don't know, I have to translate. Maybe you can help me, Andreas. Faalangst?
Yeah, we've got for anxiety disorders. We do have a group for psychoeducation. That's a psychoeducation group on ADHD and autism. So there are several groups in place, but that's something we do want to elaborate and really expand further.
Yes, because it's also so nice that you can do it for the whole region and not just for because when you have a live group, everybody has to travel. So and now we can add people from all over the area to enter the group.
And maybe one addition on this topic, we also have a group called Sharing is Healing, which means that first of all, we're gonna look at themes like hope and personal responsibility. But after that, people share without the others interacting. And it works very nice if you can share your story, so it's more or less out of you. And after that, when people have done that, maybe there's a theme we like to discuss. That's organized from the Recovery College.
Thank you, Dick. I now see that you're actually putting Q's and A's in the chat as well, so I have to sort of switch back and forth. There's another question about, do the people who use the service have any concerns about data privacy and confidentiality, about where the data goes and is used? I remember from my own experience that, and this was really at the beginning of the Corona pandemic, that some of the clients really were concerned whether I was filming the appointment. And I had to be very clear that nothing is being filmed and I wouldn't do anything without their consent. Now it seems to be that it's actually that people are quite easy, even not being concerned about their medical information. Another thing is the ChatGPT. That does bring another challenge, because with IE, it seems that people do get more aware of what's going to happen with my data, and is it all going to be put in one big place, and how does it actually work? So the whole IE idea is quite frightening, and this will be a challenge if we are really, as René explained, are making more use of ChatGPT, of other learning modules, and working with IE.
As we also have the GDPR and the legalization about the large language models. And for the clients, we also have a client portal, so they can read in the electronic client record what the practitioner has written about the treatment.
I'm trying to look at other questions.
Yeah, we had some questions indeed in the chat, Andreas.
Yeah, I can see one about writing medication on the digital platform. That indeed has been quite a challenge for us in the Netherlands, because the law in the Netherlands prohibits us to prescribe medication to patients we haven't seen physically. It was actually not persecuted during the Corona pandemic, but it's actually back in place. And we had to fight very hard as online digital psychiatrists to really get this on the agenda in The Hague and make a change to the law. That hasn't happened yet, but the Ministry of Health has given us permission to actually continue in the way we did during the Corona pandemic, that we actually allowed to prescribe medication without having seen a patient physically. So we can actually have a digital contact and prescribe medication. I don't know whether that's going to answer your question.
Yes, and we had one other above that one from Arnold Agaba, I think from Rwanda. How can we maximize AI to get solutions to mental health problems? And that's probably a question that's on many people's minds. So you as a panel would like to maybe hear from all of you how we can maximize AI for that. Maybe first Dick as an AI expert before we even know what it was, Dick.
Well, it's all about the data you put in. So that's crucial. What kind of data do we learn from? So that's really, yeah, how do we get that? And who is gonna say, okay, this is certified knowledge or whatsoever?
As they said, always rubbish in is rubbish out. We have a big data lake, but who can we train this data? And it's a challenge now.
And also being selective on data. That's something we are learning at the moment, talking about digital transformation, really being more selective of what kind of data we need and put into the system. And I think it's just a learning process. Like it's relatively new for all of us. And we just have to see where it's going to take us. And this is why we're working with the use cases. We want to start small and really see how it's going to fit into our daily work. And how it can support us. And I think it could really do a great deal in diagnostics, help us getting more information about the diagnosis. And you already mentioned word mining, for example, René. But I also think in just the whole process of treatment to really check on the patient, how he's doing. And I think it's quite frightening to some of the professionals that they actually machines, and there's been one study that machines and AI is actually better in getting information from a conversation with a client and just really hearing the difference in intonation. Just from is actually the machine is much more. It's actually much better than the psychiatrist. And that is quite scary. If we realize that some of our work we've been studying for years and years and have our clinical experience, and then realize that machine learning can actually not do the same, but help us in a way we couldn't even imagine.
Yeah, I'd like to bring in myself one experience to the audience. There's also no way to look for literature. This program was developed by a psychiatrist in the Netherlands called Evidence Hunt. And then, because indeed about what data actually do you use? Well, the data in that is only what's published in PubMed. So that in that regard, the data are reliable as they're all based on research that was published, but they use the potential, like we know it from ChatGPT, for example, that you get a sort of narrative out of it, which makes it much more fun in a way also to explore literature. So that has become for me a very attractive way of exploring literature. I see there were now some new questions in the Q&A, Andreas.
Yep, I see it as well. Can the client change the record or add to it? I think you're referring to our user portal, and that the client is actually able to look into his own patient record. They can not actually change the record. They can look at the record, of course, discuss the record with the professional or with the therapist. And they can work on certain aspects. I don't think, and then I'm looking at René because he might knows much more about the portal. I don't think they can add anything yet.
No, at this moment they only can look and read, but in the future we're gonna develop, and maybe they gonna make an appointment in the schedule of a practitioner. And they can also said van, no, this was written about me. I'm not agree with it. Can you change it, or can you put this in the electronic record?
Mm-hmm. Then there's another one. Does your government pay for all of this? Good one. How do your politicians think or talk about paying for AI in mental health? Actually, not the government, but our healthcare providers. And for children and adolescents, it's actually the municipality who pays for this. It's part of the package. Because we do believe that we offer comparable care if we do work in a digital unit. So actually it's paid for. And actually we are asked, this is the group, it's not the politicians, but it's the health insurances. They ask us to do more because they look at the waiting lists and they also see that we're being more productive and more effective working on a digital basis rather than seeing clients in an outpatient clinic. So it's paid for completely. How do the politicians think about it? Well, they some of them are quite open, and others are much more conservative and reluctant. We just had elections in the Netherlands. I'm very curious what's going to happen in the next few weeks. And health is a big topic and was a big topic during the election. So I really wonder what's going to happen with these quite progressive ideas and thoughts in healthcare with a rather conservative government. So this will always be an issue with politics and healthcare. I don't know whether anyone else would want to elaborate on that. No? Okay. Could you please tell us a bit more about running a digital recovery college? What are your experiences and what are your plans and hopes for the future? Dick and René. I think you are the ones who can.
Yes, Dick, help me, but it now is very small. We thought about a minimal value product. We have a group about drug addiction. We have a group about healing. We have a group for our spiritual practitioners. But it's very small, and we have a lot of ideas, and we want to have a good website, and we want to use social media, but it's an idea, and it's our plans, and we'll make it. And we started small, and we have to make it bigger, great. And now we have 3 peer workers: Marike, Dick, and Helen. They enjoy us to work in the ideas. Maybe Dick, you can.
Yeah, well, my hope is that for the Digital Recovery College, the peer worker is central and that the client is central, that it's very easy to connect, to communicate, etc. And we have to link to other relevant data and maybe some videos on it that explain the treatments, etc., etc. But my hope is that it's a really personal tool, linking to relevant data. And like Nancy said, 24/7, that would be perfect. That you can do an awful lot of work yourself, that you can make your treatment plan, for example, or your concept treatment plan, etc., etc. So, yeah, that's what I hope for, and to keep it small and simple as well. Because otherwise we go too big and it takes too long, and nice and easy. That's what I hope for.
Thank you. I'm just looking further. There are more questions coming in, so I'm trying to check the next. You said there were peer supporters in your team. Could you tell us more about what they do in the digital team? We do have peer peer supporters, peer experts in our child and adolescent digital unit. There are actually two. They join us on every meeting. We have multidisciplinary consultations with the whole team, and they're always part of it. They make sure that we use proper language also with each other. I think they're very keen and good on telling us, make sure what you say, how you say it, and how it's being perceived by clients. So that's very helpful in our discussions when we talk about clients in the team meeting. But they also will join us when we actually see patients for an intake. And there is an option, if they feel more comfortable with a peer next to them, that they can actually ask and have someone join for any session, not just an intake, but any session really. They want someone next to them. So it's quite new for us. I think, Nancy, they've been with us now for a couple of months on a regular basis. And I think it's a very valuable addition to our team. Is anything else, Nancy?
No, I guess that's it. But I was curious how Dick, if Dick can explain more in the because he's of course added to the adult team. So I don't know if it's different there.
In the 100% online team for adults, we are always there at the intake. We are there at the reviews every 2 months or so. And we can have three individual sessions with the client. So that's the amount of work. And that's besides what we do for the Recovery College, like what I said, sharing is healing, for example.
Yeah. It's not really a discussion we can have, because I never really know whether your answer is being your question is actually being answered properly, or whether it's elaborated enough. So if you do say, well, I want to know more, just put it in the chat or in the Q&A.
And actually, people can come also live if they let know they want to be live in the webinar, they can, then Ovidio can arrange that.
Oh, please do, because I would love to hear from your experiences wherever you work and live. So then there is.
We have both questions now in the chat and in the Q&A.
Yeah, I'm trying to do.
Shall I look at the chat and you look at the Q&A?
All right, that's a good one. You want to take the next one, René?
Yeah, where did I stay? Oh yeah, here from Basma Tolba. But there's a question about the challenge of writing medication on a digital platform. How does it work?
I think that's what I just answered. That we actually are able now to prescribe medication on the digital platform, and it's okay to just see the patient by video conferencing, and we don't actually have to see the patient in person.
Yeah.
Then there's one by
I have here one from Daniel Agabo. How can digital mental health tools support students' mental health?
That's a very good one, because we realized that we have to address and include our students right from the start. So as soon as we started with our digital unit, we also started with a digital internship, because we wanted to have medical students, psychology students working with us, doing their training with us, to actually also get their digital training right from the start. And this is something. It's just like what Nancy told us. It's really easy to get new colleagues because actually people are applying to work for us instead of that we actually have to look for them. And it's the same with the students. Actually, the students will ask us to follow a digital internship because they know this is really some important tool I need to get working, even if I don't work 100% for a digital unit, but I will do some work, however, digitally. So this is something we do as, and we want to standardize it. And we've also been working on the whole issue of schooling and working with the universities. We're training the students that they actually make it part of their curriculum. So we have been adding our digital part to the curriculum. And there is, we call within the group of Dutch psychiatrists, we have a digital innovative platform where we actually try to get that information all together. And we also write on a report on students and digital internships. So I actually think this is one of the keys to get them as soon as possible into working in a digital way and get them acquainted with it.
Andreas, I was wondering if the question was, because the answer I fully see, but the question was like, how can digital mental health tools support students' mental health?
Sorry.
So I guess the question was maybe how we support the mental health of students. But I'm not sure, but that's how I read it.
Yeah, I think that was what the question was about. It was very interesting to think about the curricula of the
Yes.
study, but indeed, but the question seems to be more that about the mental health of students themselves. Can one of you reflect on that?
And I'm wondering what the answer would be like at that question. I don't know if we specifically have any tools for students, but Andreas, maybe you can help me. I don't think there are specific tools for students that we have online.
It's not that we have them, but I know there are tools for students at school, students at university level as well, and they actually came in place during the Corona pandemic when we saw really an increase in mental health problems and long waiting lists, and there was actually a way to get in contact with mental health professionals in an easier way by a digital contact. I don't know whether that actually answers the question, but we don't, as you say, we don't ourselves really offer any programs on that.
There was another interesting topic in the chat from Jeanette Houan, I think from Norway, about forced treatment, coercion. Of course, no, we had a lot of debates about that, about the possibilities and obstacles there. Can you share that with the audience? The question was, does psychiatrist assist patients who receive forced treatments in form of medication treatment outside hospital in digital meeting with patients?
Yeah, this is another interesting point, and indeed a point of long discussions with the courts. We worked. I also work as a chief psychiatrist and actually work with the forced forms of treatment, following the laws, of course. And we did the assessment in a digital way. As I told beforehand, we would actually have the psychiatrist on call, do the assessment. And this would also be assessment for forced treatment. And the courts actually told us that we are not allowed to do that anymore, even though the law doesn't explicitly say whether we have to see a patient physically or online. But the court and also the High Court in the Netherlands actually told us not to do it anymore. which makes it really difficult for us because we have to find a way, because we are convinced that it works better for the patient, because the patient doesn't have to wait for hours before a psychiatrist is actually there in place to see the patient physically. And so what we actually decided, and we checked with the court, and they agreed on that, is that we do the hybrid form. So even if we talk about forced treatments, we would see the patient, two people, the resident and the psychiatric nurse would see the patient at the location physically. The psychiatrist will be seeing the patient via video conferencing and getting information from the nurse and the resident. If there's any doubt, of course, the psychiatrist will actually travel to the location, but this might take hours. We really have a huge catchment area, and it means like a psychiatrist might actually have to travel for a couple of hours to see a patient. But what we decided to do, and the court agreed, is that we will always a psychiatrist will see within 24 hours the patient physically. So there will be another psychiatrist who will actually confirm the assessment done digitally before. And that's the way it's agreed on for now, but it's for us, it's quite a challenge to really get this sorted out. And we see that the whole judiciary is not really working together and seeing really that this is the future and actually being more client friendly as well. We don't hear you, René.
There was another question from Norway, from Vegard Haaland, about the resistance. Did you experience resistance from professionals or among professionals when it comes to working clinical on a digital platform? Did we?
Nancy.
Yes, of course we did. Yes. It's a long road, I guess, and not everybody is as enthusiastic about working online as we are. But mostly we found out that patients are more enthusiastic about working online than our co-workers are. So that's a big, I don't know how you call it, but we use that to show to the colleagues that the patients would like to work online. But of course, not all patients would like to work online. So not all the co-workers like to work online. So they find each other and we go further online. But we notice that there's a lot of yeah, I would like to say cold water, but I guess it's a Dutch cold feet, maybe. Yes, cold feet, I guess. To first start and try to work online. So we have to try, and we have to try to make people want to try for the first time, and then they notice it's very alike, and it's very okay to do it online. So.
Once I had a discussion at a psychiatric meeting, and I said, digitizing is an impoverishment of my work as a psychiatrist. And 50% raised their hands. They agree with it. So yes, there's a lot of resistance. And now in this presentation, you think everybody by GGZ Noord-Holland like to work digital, but it isn't. But it's my job to make them enthusiastic about it.
Thank you. You do the job really well. Yeah. Otherwise, two more questions coming up now.
Yeah. Have you any published evidence? Oh, sorry.
Yeah. Okay.
Have you any published evidence about the views of your clients to say that it's more client friendly, the hybrid assessment? We've done research on that during Corona, but this would only be for our group within our own organization. And actually, people were people had a choice, and people who chose, they really they were very positive, actually more positive about the hybrid form or the digital form than the actual treatment as usual at a location. And this was for both groups, adults and children and adolescents. But this has only been published, I think, internally. Like, we haven't really published that internationally. Do you find that groups of patients do not have online access or are living in places where it's difficult to speak comfortably online with you? How do you include them? I think that's an advantage in the Netherlands, the coverage of internet and everyone really having, it seems to be one of the basic life means. So everyone has a high-speed internet access, really. Even people on welfare, I believe, will have, because it's sort of considered a basic mean, and lots in the Netherlands is actually being done digitally. So the communication with the municipality you do via the internet. So I don't really think access is a problem. There might be some people who have problems using it. And there's certainly the elderly who have problems using the internet and also using forms of digital treatments, but it's not a question of access. And now the question is gone, because there was another.
When it's answered, then I think
Okay.
you removes it. So I think at the moment we covered all the questions that were there. And unless we see a new one coming up, I would like to tell you briefly about upcoming events of EUCOMS before I give the final word to Dick. I see one new question now, I think. I don't know, that was already there. Yeah. Thank you all very much for having been with us, and thank you for Andreas for the actually chairing and for all the presentation from Renee and Nancy and Dick. We were going to see again, but before we give Dick the final word, I want to announce you upcoming events of our network. And as already mentioned, we have these webinars at least 4 times per year, but we are open for, if you have an additional topic for an extra webinar, please reach out to us, and then we can make place for that, because we have the techniques here to organize it. But so the first upcoming webinar you see on the right, it's about the models of care in Greece, and there's very interesting developments in Greece. One of our partners and active participant EUCOMS is the Society of Social Psychiatry in Greece. And they've been really pioneering a very long time already with working with mobile teams, and they're also very up to date. For example, with the many refugees there, they also look after that. So it's, for me, always very inspiring to be in Greece and see what's happening there. So I really welcome you to come to the webinar on 31st of January, same time, and also on Zoom. You also see a QR that you can scan, so that you have more information on how you can register. And apart from the webinars, 2 times per year we meet on a location somewhere in Europe, and that's when you see on the left side. Our next meeting will be in Cologne in Germany. You see here the beautiful skyline of Cologne with the cathedral and the bridge over the River Rhine, and we will meet there on March 14 and 15. And you can register, and we hope that we have also a very international audience there. We have a very promising program, as the city of Cologne is very active in the social psychiatry. So having said that, I would like to have the screen back on Dick, so that Dick can have the final words of this webinar with a reflection on what we've just been through. Dick.
Well, I've been given 3 minutes to reflect on this meeting. And in the closing, I can look to the webinar as it has just happened, my feedback on the approach of the topic, the language we use, and anything else I'd like to comment on. Well, I took some notes, which I'd like to share. We had a little over 30 participants. And after my pessimistic intro, Andreas showed us some clear achievements. And he said, digital mental health is inspiring, exciting, and here to stay. Well, I believe it's here to stay, but is it already inspiring and exciting? And is it inspiring and exciting for the client? Nancy started off with care as usual, only digital. And I thought, oh no, that disappoints me. But in the end, she said, but there are much more possibilities. So I think we have to rethink the kind of care we give. And the flexibility. What I find an interesting issue is that the two parents can be at the appointment while they're both working. That was a nice example, I think. Challenges, Renee mentioned, youngsters say no when it's no fun. So I think let's make it fun. I can't wait till the digital recovery college caterpillar turns into the butterfly. And without being rude, the language we used was a kind of Dutchy English. And anything else I'd like to comment on? AI, it's been 37 years ago since I graduated on the University of Amsterdam. Maybe it takes another 37 years to be successful. I don't know. Thank you all for joining.
Thank you, Dick, and thank you all, and see you again next occasion.